It's hard not to talk about palliative care and hospice without invoking the memory of the great late Dame Cicely Saunders. And this was a photograph that was taken of the two of us on the occasion of our very first meeting. And in case you're wondering why the two of us might be looking so happy, it's not just because I am delighted to meet her, and I'm hoping Dame Saunders was delighted to meet me. But it was 10 o'clock in the morning. This was Dame Saunders' liquor cabinet, and her only question to me when I arrived was whether or not I would like to join her for a glass of sherry. And these are empty sherry glasses. This was at 10 o'clock in the morning. I was about to go off and do a lecture for all of the faculty at King's College. But when Dame Saunders invites you to have a sherry, even though it's 10 o'clock in the morning, there is only one response. And the answer, of course, was yes. Now, the next time that I went to London, or actually this was the last time that I went to London, from there, I had the honor of being invited to give medical grand rounds at Oxford University, which was something that I had really hoped to do before the end of my academic career. And one of the people that I met there was also somebody who had very much been a hero of mine, and that is Robert Twycross. Robert Twycross was one of the first people that Dame Cicely hired when she started St. Christopher's Hospice. And his contribution to palliative care, just as Dame Saunders, was enormous. Robert Twycross was responsible for some of the early studies looking at the role of opioids in terms of managing cancer-related pain and malignant pain. And he certainly was a pioneer, not only in palliative care, but I think of him being a pioneer in our quest to try and quell human suffering. Anytime you hear a palliative care researcher talking about palliative care, very oftentimes you'll find that we use these paintings, or we point to these paintings that were created by a Canadian artist from Nova Scotia by the name of Robert Pope. And Robert Pope was just a magnificent artist, and as he himself was approaching his own end of life, he produced this incredible series of paintings. This is one of his lesser known pieces, but it's one that I have been using lately in my presentations, because when I look at it, I see somebody teetering on the water's surface, and it has me thinking about all of the forces that may keep someone buoyant and the countervailing forces that threaten to pull someone under. And when you think about human suffering, we need to think about the things that keep people buoyant, that keep people feeling like life is something that they savor and continue to want to live, as opposed to the things that pull people under and turn that final time towards the end of life as a time of simply waiting for death. What happens when people are in a state of waiting for death? Well, they report a heightened desire for death. And desire for death was one of the very first things that I studied when I began publishing back in the mid-1990s. This was an article that we published in the American Journal of Psychiatry. It was an article that was comprised of about 200 people, all of whom were in palliative care, which means that all of them had a life expectancy in order of magnitude of 6 months or less. About 80% of them had an end-stage malignancy, and average age was early to mid-70s. That really describes the demographic of all of the people that we have studied over the course of several decades of this kind of research that I've been doing. We reported that a small minority of patients actually had what we recorded as a genuine desire for early death. Some were just under 10% or so. And when we try to differentiate, what characterizes people who no longer want to be alive, who have a desire for death. And maybe just before I say this, this predates any legislation in Canada around medical assistance in dying by 30 years. Our Supreme Court and our government in Canada did not bring about legislation for assisted dying until 2016. This article was published 30 years before. Nevertheless, these people, we ask them about desire for death, which isn't necessarily a wish for hastened death, but a wish that life be over sooner than later, with hastened death sort of being at the extreme level of endorsement. And when you look at what differentiates somebody who wants to go on living versus somebody who desires death, what you find is that there are a multitude of influences, and those influences come from physical sources. For example, pain. 80% of people who wanted to die had pain of moderate severity or greater in 80% of instances. They also had the perception that their family was less available or less supportive. And then finally, we did find that depression was a significant player. Nearly 70% of people who had a desire for death met diagnostic criteria for syndromal depression versus only around 10% amongst those who did not desire death. I think that the numbers are less important than this idea that if you're going to understand what I refer to as this kind of experiential landscape of desire for death in this instance, you need to look at it from a multitude of vantage points. You need to understand physically what is happening. You need to understand in the terms of psychosocial or environmentally what is happening. And you need to understand the internal environment, which is really about the psychology, the spiritual issues, the existential issues. And it's that multiplicity of approaches that is going to give you a holistic understanding of what somebody is experiencing. After the Desire for Death study, we went on to produce a study that was published at the end of the 1990s in the British journal, The Lancet. And the reason that we went about doing this study is that the Desire for Death study, in some ways, was using what I would call an inaccurate metaphor, and that is a metaphor of a photograph. And a photograph catches something, it catches an image in cross-section. The one thing we know in palliative care with certainty is that nothing stays the same. Whatever you see this morning is not necessarily what you'll see later on in the day or this evening when you walk into the room of somebody who's dealing with an advanced illness. And so we did a different study which applied, I would say, a different metaphor, and that's a metaphor of kind of a video. In other words, we measured, in this instance, will to live every day, twice daily, for patients from the time they came into our palliative care facility until the time they could no longer provide data. And again, this particular study, and again, you can look up the details in the Lancet, had about 200 patients. I've just parsed out one patient. This is an 80-year-old woman with end-stage colorectal cancer. Anything that scores high on a visual analog that was part of an instrument called the ESAS, the Edmonton Symptom Assessment Scale, which is a multidimensional instrument that measures various kind of sources of distress that are common in palliative care. You can see that initially, and this is in yellow, her will to live, the score is high, which means there is a paucity of will to live. It immediately improves, so her will to live improves once she's admitted to palliative care. And towards end of life, it becomes more erratic or more erratically reported, beyond which we no longer collect data because we no longer feel the data is reliable or meaningful. What's extraordinary about this kind of data is you can also look at concurrent sources of distress. So in this instance, I have mapped her subjective reporting of pain along with her will to live. And you can see, again, if we're using the language of metaphor and dance, this is a tango. In other words, there's an intimacy between her experience of pain and will to live. We can't talk about cause and effect, but we can say is that perhaps as her pain improves, so too does her will to live. Or conversely, once we have now supplied her with the psychosocial supports, the existential supports that she requires, the spiritual supports, it mitigates her experience of pain. We can silo these things as we tend to do in palliative care and in medicine. There's a pain specialist, there's the spiritual care specialist, but the truth is, treating pain can have profound spiritual implications, including enhancing the wish of somebody to go on living. More recently, I've also been looking at, what are the drivers of loss of will to live? And we had discovered in some of our work that amongst patients nearing death, no longer feeling like me, no longer feeling like I am the person I once was, is a profound existential issue. I have coined this or used the phrase fractured personhood, sort of a sense of brokenness, if you will. And this paper that came out just a couple of years ago in the Journal of Palliative Medicine poses the idea that perhaps these insights that we're garnering near the end of life or gleaning near the end of life apply across all of life. I mean, the things that I'm going to be telling you today about kindness and compassion and dignity, it's true those emerged from conversations and from research that we did amongst patients near the end of life. But palliative care doesn't have a monopoly on the importance of those issues. And as it turns out, those things are important across all of medicine. And so we began to look at whether or not this notion of brokenness, feeling fractured, might have implication in terms of suicidality and understanding suicidality across the entire life cycle. And this paper, which I think, I'm really quite taken. This was done by a young man who was just completing his psychiatry residency. And he used a measure of dignity that we developed, the Patient Dignity Inventory, applied it to a group not of palliative care patients, but a group of patients who were now in a psychiatric facility. And he measured their endorsement of dignity along with depression and suicidality. And lo and behold, what did he find? He found that understanding dignity was profoundly and significantly associated with suicidality, which means if we are going to begin to understand in more detail what drives people towards a wish to die, not only at end of life, but throughout life, we need to be mindful of this landscape of human dignity. So let me kind of tell you how I then segued in my research career from looking at desire for death to dignity. Now, at the time, as I said, this predated Carter, which is the Supreme Court decision that heralded the onset of the MAID legislation, by decades. But in the Benelux countries, Holland, Switzerland, these practices around death hastening, euthanasia, assisted suicide, had been going on for many years. And as a psychiatrist, I was interested in trying to understand not only how often people were availing themselves of what they referred to as MDEL, medical decisions to end life, but why were people motivated to walk that particular path? I mean, in Canada, of course, that was not available. It was only a hypothetical to say, would you, if it were available, would you no longer want to go on living or would you want to hasten death? Whereas in the Benelux countries, this was happening in real time. And so we discovered this incredible study. Again, this was published in The Lancet, early 1990s, the first author, Paul Vandermaas. And this research paper really changed the direction of my studies because Vandermaas went back to the death record for people whose deaths were accounted for by euthanasia and assisted suicide and identified the physician of record and asked these physicians, what do you think motivated your patient to seek out your assistance in hastening their death? And this is the very first time that the idea of dignity as being something that I ought to be thinking about occurred to me. Because according to the Vandermeer data, pain alone only accounted for 5% of the reasons these Dutch physicians gave. And pain is part of a constellation of symptoms, 49%. But loss of dignity was the most highly cited reason, according to these Dutch physicians, as to why their patients had actually sought out death. And so we decided, if dignity is worth dying for, then dignity is worth studying. What's the first thing you do when you study something? You go to the literature and find out, what do we know about it? Well, what we found out about it was dignity was highly cited in the medical literature, but it was also highly politicized. And by that I mean, no matter what side of the political fence you sat on, with whatever contentious issue you might think of, people would use dignity as kind of a final trump card. And for example, you might say that, if you were arguing on the side of the political fence that said, euthanasia should be available because this is about my body, this is my autonomy. Ultimately, this is an issue of control and human dignity. And that's a very powerful argument. On the opposite side of that political fence, you would say, this seems to be a violation of the Hippocratic Oath. This could undermine trust in the patient, care provider, relationship, the taking of human life. This is fundamentally a dignity issue. We came at it and said, we're not the moral police. We're not coming at this with a political axe to grind or with a moral precept that we want to try and prove. We want to understand what dignity means to patients at the end of life. And we're not going to ask the physicians who looked after them. We need to go to the bedside and find out from patients themselves what we can learn about human dignity. And so that really was the entry point into the first studies of dignity in the terminally ill. Up until then, there had been no studies. So almost 8 years after I discovered the Vandermeer paper, I published this paper again, ironically, in the journal The Lancet, looking at measuring dignity using a measurement that was modeled on a standardized instrument called the Schedule of Affective Disorders and Schizophrenia. It's just a way of using a template to try and develop a measure for which no measure existed. What you can see from these results, and by the way, in case anybody is worried about taking notes, I'm happy to provide the PowerPoint slides. Suzanne can send a PDF of all of the slides. So if you want to look at it and study it more closely, feel free to do so and to relax about not having to get down all of the details as I'm going through the slides. You can see that in at least half of instances, loss of dignity was not something that these 200 plus patients reported, which means that in the rest, loss of dignity was something that at least occasionally occurred to them. So it says that we in palliative care need to be aware that this is not an unusual concern for patients, but in a smaller minority, in 7%, reported that it was significant. So they scored 3 or greater, moderate degree, which means that they see this as a significant problem. It's there almost all of the time, always present, virtually total loss of dignity. Now, we then went and did something very similar to the desire for death analysis. We said, well, what differentiates people whose dignity is intact versus those whose dignity is broken or fractured? And many of the things are not surprising. There's more physical issues. There's more problems with intimate dependencies like bathing, dressing, toileting, psychological issues, higher desire for death, loss of will to live, and so on. But here is what I consider one of the most profound kind of research epiphanies. And that is when we did the analysis, the thing that came out as the strongest predictor of variance of human dignity, or dignity as we measured it in this cohort, was appearance. How people perceived themselves to be seen. Now, for me, this was an epiphany because up until then, I'd always thought about good palliative care as being what we do to patients or what we do with patients. And now the data was saying how we, the care provider, see patients, their perception of how we appreciate or don't is the most significant determinant of whether dignity is held intact. And so I published a separate article based on that in the Journal of Clinical Oncology. And I called it Dignity in the Eye of the Beholder. And even though it's based on empirical data, metaphorically, what I say in the article is that patients are looking in the eye of the healthcare provider for a reflection that will be affirming of their sense of dignity or their sense of personhood. And then years later, I discovered this incredible etching by the Dutch graphic artist M.C. Escher. I think it may be a compilation of two of his etchings that I discovered online. And it's a self-portrait. And I choose to call it the reflection in the eye of the healthcare provider. You can see Escher in his apartment, surrounded by his belonging, his books, his pictures, photographs, and so on. This is an affirmation, as opposed to what patients might experience, which is to see a problem checklist, to see a differential diagnosis, to experience themselves being perceived as the embodiment of an illness. And this is the problem that I have called in my writings, the problems of patienthood eclipsing personhood. And of course, we know, if you have read the work of Eric Cassel and his papers on the nature of suffering, when people feel that personhood is under threat of disintegration, that is where suffering becomes proportionate. So if this is the case, if our perception, if our gaze as the healthcare provider is so profound, we need to take very seriously understanding the gaze of the healthcare provider. By way of summary, what we can say is that, objectively and externally, we oftentimes, find ourselves dealing with patients in a very transactional way, as opposed to in a relational way. And by transactional, it means we are trying to understand the pathology and the psychopathology or the pathophysiology. And we are, of course, interested in diagnoses and differential diagnoses and problem checklists and therapeutic opportunities. And at the center of it all, though, is still a patient needing, wanting, yearning to be seen. And what we're talking about is the kind of suffering that's commensurate when people feel that they are not seen. At one point, I published a paper in the British Medical Journal where I tried to say, in medicine, we are all accountable for the ABCs of critical care: airway, breathing, circulation. None of us in medicine could absolve ourselves from that responsibility if we we approach a patient who's not conscious. But when it comes to the human dimensions of providing care, we tend to say, be a good person, trust your gut, do what feels right. And we know that that's insufficient. So the ABCDs of dignity conserving care say, A, your attitude, as I've pointed out, is of profound importance. B is for behavior. Do you sit? Do you stand? Do you meet someone's gaze? Do you not meet someone's gaze? And we know that those things make a profound difference. There was a wonderful randomized control trial of sitting versus standing in orthopedic surgery. I didn't do it. It was conducted by others, who showed that when surgeons are randomized to sitting, their patients actually experience them being present 5 times longer than they were there, with a satisfaction rate of the encounter in the magnitude of 90%, versus when they are randomized to standing, same physician, same conversation, you don't get the same kind of distortion in perception of how much time they were there, and level of satisfaction is only between 40 and 50%. Compassion Compassion is about understanding the suffering of another person and the willingness and attempt to mitigate that suffering. So my postdoc, or former postdoc, Shane Sinclair, who's now considered a world guru in the area of compassion, says compassion is a verb. It implicates action. And D is for dialogue, the kinds of conversations that acknowledge personhood, which I'll be talking about. Let's loop back to Dame Cicely Saunders, who famously said, and this has become kind of a central tenet of palliative care, you matter because you are you, and you matter to the end of your life. We will do all that we can, not only to help you die peacefully, but also to live until you die. So I began thinking about that and wondering, well, how do you, in fact, approach people who feel that they no longer matter? So this was invoked, of course, by Dame Cicely, but although she gave us this, important, what has become, as I say, this important kind of a foundational adage of palliative care, it doesn't necessarily provide us a how-to. How do you provide care for people who feel they don't matter? And if we have somebody who is physically in dire straits, we provide them intensive care. They go into an intensive care unit. If the nature of their distress is spiritual or existential or psychological, what about the idea, and this is where I coined the term intensive caring? This was published just a couple of years ago in the Journal of Clinical Oncology. Again, it's open access. It's been downloaded at this point thousands of times. You're welcome to go and to check it out further. But I'd like to walk you through the 5 primary tenets of intensive caring. The first of which is non-abandonment. Now, think about what are the dynamics of abandonment in palliative care, in all of medicine, really. The dynamics of abandonment are feelings of impotence, feelings of helplessness. If I, the care provider, feel I don't have a way of fixing whatever ails you, the temptation is to withdraw or to never enter into that situation, to say, that's really not part of medicine. We'll call in the social worker, we'll call in the chaplain. The first tenet of intensive caring, if you're going to be working in the presence of people who are experiencing suffering, and suffering isn't readily fixable, the first thing you need to do is to show up. And we have good evidence. To show that just showing up makes a difference. There's a wonderful study that was done by an American oncologist, Kelly Trevino, and she looked at the fact and reported the fact that the connection between the medical oncologist and patients with advanced malignancies was the strength of the connection between the patient and the healthcare provider, even more so than psychotropic medication. So showing up matters. In her paper, showing up made the difference between life and death. And Dame Cicely, by the way, also famously said, suffering is only intolerable when no one cares. So to show you care, you need to first and foremost show up. If you're going to show up, what's the next tenet? The next tenet is you need to take an interest in this person. Who are they? And that's going to enhance empathy, respect, connectedness. And it also is going to affirm who they are, who they were, who they tried to be. In understanding the person, I'm reminded of a publication by Stuart Farber. Stuart Farber was a palliative care physician, died too young, worked in Washington State and Seattle. And when he was approaching end of life, he talked about, and in fact, this was published in the Journal of Pain and Symptom Management. He said, with rare exception, the clinician who treats me have good hearts, care deeply, but possess little or no knowledge of my thread. And this was a metaphor that he used to describe the essence of who he was. And he concluded by saying, without knowing my thread, it is impossible for a clinician to provide respectful care. And I would add to that, we all we all talk about the importance of person-centered care. Everybody talks about how important person-centered care. I would point out that in the absence of knowing persons, you can't give person-centered care. So knowing the thread, taking an interest in the person is critical to, and certainly is the next tenet of intensive caring. Other ways of putting personhood on the radar, it was mentioned in my introduction that we introduced and studied and continue to study dignity therapy. Dignity therapy is based on the notion of generativity. It is the most studied non-pharmacologic intervention in palliative care today. There are well over 100 papers. There's over a dozen systematic reviews, all attesting to the impact of dignity therapy, being able to mitigate suffering, depression, quality of life, and so on. To give you a flavor of what it looks like, the first patient that I invited to do what then was the very beginnings of dignity therapy was an older gentleman, end-stage cancer. He had gone on a hunger strike, said he was no longer going to eat and drink because, to quote him, breathing had become redundant. In other words, what was the point? There was no enjoyment anymore in life. So, and he told me that if he could press a button in a European country, he would press it now. And you know exactly what button he's referring to. So I introduced the notion of dignity therapy. I said, we could come, or I will come, have a conversation with you. Don't worry about what to say. I will lead you through a conversation that is going to be in part biographical, but in part allow you to share things that you want to share with people that are important in your life. He was intrigued. By the way, I did a psychiatric evaluation. He wasn't suffering any syndromal psychiatric disorder whatsoever. Came back, we had a wonderful conversation about his family, immigration, his children and their successes, the tragic death of one of his children, his wishes for those who would survive his death, and some particular kind of instructions or directions or hopes and wishes for his wife who would survive him. We went off and transcribed it. It goes through an editing process. By the time we returned it to him, he was too weak to take it from our hands. And it was within the week. There's an ethos of immediacy. And his wife knew all about this and took it from me and said, this will be a blessing to our family. So I'll always remember that that's how she received it. Since then, as I said, hundreds of papers, over a dozen systematic reviews. The most recent one, the last author was Yanez. It was published just within the last few weeks, a young man from Brazil, a wonderful scoping review on dignity therapy. And dignity therapy, although it was originally designed in palliative care over the 20 years, has moved into other areas. So these are studies of dignity therapy in patients who are incarcerated. There's been studies of patients who have serious mental illness, patients who have some degree of cognitive decline or impairment. Another instrument that we've used to try and elicit personhood is what I call the patient dignity inventory. And again, because of detail, I'm not going to be able to kind of dive deep into the details of that, but it covers physical, psychological, existential, and spiritual issues that patients might report as a problem. Everything from feeling pain to, I no longer feel like I'm the person that I once was. What's interesting is that when you have a new instrument, it's like having a telescope or a microscope that allows you to see things that you couldn't see before. What can you see when you apply the patient dignity inventory? Well, amongst the highest rated things that patients say are problematic, after routines or distressing symptoms or not being able to carry out important roles, over a third of our patients say, no longer feeling like I'm the person who I once was. And routinely we ask people about pain and bowel movements. When's the last time we asked a patient, do you still feel like you? Do you still feel like the person that you once were? And it turns out that that's a profound existential question. One of the ways that we've tried to put personhood on the radar is by using something called the patient dignity question, What should I know about you as a person to help me take the best care of you possible? So we go to the bedside, we say we know a lot about you physically, but we don't know a lot about who you are as a human being. And we have a short conversation in which this question is kind of the foundation. This discussion is then summarized into, which takes only 5 or 10 minutes. It's summarized into a couple of paragraphs. We come back and we read it to the patient. We allow them to make any editorial changes. And then finally, the litmus test, do we have permission to place this on your chart? We've studied this with, a couple of hundred patients. Now, collectively in the medical literature, there are thousands of people who have been given the patient dignity question. I'm not aware of any instance where a patient said, I don't want that on my chart. From our data, patients say the information is accurate. These are just rounding errors. All of them say they want it on their chart, and they feel it could affect their care, and they would recommend it to other patients or family members. And clinicians who read these documents say 90% of the time they learn something new. And even though this was done in palliative care, where people are wired for empathy and compassion, in 45 to 65% of instances, clinicians reported that they felt it heightened connectedness, it heightened respect, it heightened empathy. I think I'm going to skip this because of time. This instrument has now been translated into about 20 plus languages, including German. And again, I will send you the PDF of these slides so that you can see them. If we are going to take this notion of personhood and our gaze seriously, we need to think about what shapes our way of understanding what patients might want. Intuitively, we usually respond by invoking the golden rule. I will do to you what I would want done on behalf of myself, right? Or on behalf of somebody that I love, a family member. And that's a good starting point, although it does impose this external standard. It's saying your lens then needs to become this kind of gold standard barometer of what patients may or may not want, which can lead to a sense of therapeutic nihilism. What if you end up saying, well, I don't know if I would want to be that sick or that old or that disabled or that marginalized. So that can result in advice that's based on avoiding a future that you, the healthcare provider, might find untenable. And that, of course, leads to discordance in goals of care, which is why I, a few years ago, introduced something that I've referred to as the platinum rule. And the platinum rule says, doing unto patients as they would want done unto themselves. It's not the case that that means all people get all things all times, but it means it's always important to understand the patient's lens, the patient's perspective. And the very first paper that introduced the platinum rule came out in 2022, so 3 years ago, in the Journal of Palliative Medicine. And it described an elderly man who had a head and neck malignancy, and a dialogue between him and his medical oncologist, who said, at some point, things may go very poorly, at which point you may want to consider medical assistance in dying. And the rest of the article really tries to explore, well, what goes on in the mind of the healthcare provider who might be offering this as an alternative? Whose lens is he looking at this situation through? His own, which sees with horror what might be lying down the line, or the patients who really had no interest in a medically hastened death whatsoever. So the platinum rule says we always need to consider the patient's perspective. I think it's an important foundational element of what we refer to as equity, diversity, and inclusiveness. It helps us confront our own biases, and it's an important standard for substitute decision making. If a person can no longer speak on their behalf, the question of the healthcare provider is not, what would you like us to do with your father, mother, sibling? The correct question is, if we could bring them into this room, what is it that they themselves would want? That, I would say, is invoking a platinum standard and raising the bar on person-centered care. We're almost done. Suzanne, can I take another few minutes? Yes, I'm getting the thumbs up. The next is the tone. Your tone when you walk in the room. I call this a dignity-affirming tone or therapeutic presence. This is based on a study that we did many years ago, and I can give you the references, looking at elements of optimal therapeutic communication. And it has to do with empathy, being non-judgmental, authentic, trustworthy, being fully present. Many people say, I just don't have the time to do any of this. Well, if you have 2 minutes and are mindful to being fully present and non-distracted, you can take that 2 minutes to be fully present and make a good impression. Or in that 2 minutes, you can act like somebody who only has 2 minutes and is in a rush and is distracted. The next tenet of intensive caring, this is the fourth tenet, is knowing what is possible. When my mother was dying a couple of years ago, I remember when my older daughter walked into her room. She was already on her deathbed, and my older daughter took the opportunity to thank her grandmother for making her entire life better. It matters. If patients are helpless, if family members are helpless, helplessness is contagious. But if we who enter into this space of suffering understand what is possible, conversations are possible, reconciliations are possible, a final goodbye is possible. We're now doing a study in which we're speaking to people who have requested medical assistance in dying. And we spoke to a man who told us the reason he's chosen this is that he watched his grandmother die a bad death, and he's not going to go that route. So even knowing that how somebody dies provides a template for how we ourselves, the witnesses, will approach our own death, that is part of knowing what is possible towards the end of life. And then the final tenet of intensive caring is humility. If you're going to enter into this work, you need to understand and tolerate clinical ambiguity, honor the patient's expertise, trust the process. The article ends by stating that therapeutic humility sees notions of fixing yield to commitment to understand the nature of the patient's suffering while creating a safe space to bear witness, to validate, and to comfort. So in some ways, and in summary, intensive caring really is a paradigm shift. Traditionally in medicine, what do? We examine, we diagnose, we fix. It is the reason why many of us went into medicine. It's an extraordinary thing to be able to do. Those of us who spend lots of time in medicine or have lived long enough know that not everything lends itself to that paradigm. There are things in life that cannot be cured. There is suffering that cannot be taken away. We still have a role by applying intensive caring, which means examination yields to who is this person, diagnosis yields to understanding the nature of their suffering, and fixing yields to providing comfort. So I'll close by saying that a couple of years ago, I gave a lecture for what's called the white coat ceremony. This is when the medical students put on their white coats for the first time, the new class when they enter into medical school. This is a QR code for those of you who want to listen to the speech in its entirety. But there are a couple of things that I shared with the medical students that I'll share with you. One is strive to be more than human body mechanics. Aspire to be healers. The second, the way we are with patients and our attitude towards them will profoundly shape every single clinical encounter and their illness experience. And finally, patients will not care what you know until they know that you care. With that, I'd like to thank you for this honor. It's been my delight. By the way, my book, Dignity and Care, The Human Side of Medicine, I'm pleased to announce that I understand it will be coming out in German this fall, thanks to Professor Roland Hanke. And my next book will be coming out in November, called In Search of Dignity, A Lifetime of Reflections. That's my contact information. I invite you to follow me on either Twitter, X, or LinkedIn, where I keep up all of my professional activities, access to information and publications for those of you who are interested.